السلام عليكم ورحمة الله وبركاته. معكم زميلتكم سديم دهام، أتمنى أن الجميع بأفضل حال. اليوم بإذن الله بشرح محاضرة المود Disorders لروتيشن السايكايتري أو الطب النفسي لسنة خامسة. قبل ما نبدأ ودي لو نعرف أن اضطرابات المزاج البريفالنس حقها جدا عالي، ومن أكثر الاضطرابات شيوعا بالطب النفسي، ومو عيب ولا حرام أنه الشخص يمر بفترة يعاني فيها من أي مشكلة نفسية، ونحن كأطباء مستقبليين لازم نساعد على كسر الستيغما المحيطة بالأمراض النفسية ونكون خير عون لمرضانا. With that being said, let's begin. What is mood exactly? Mood is a pervasive and sustained feeling tone that is experienced internally and that influences a person's behavior and perception of the world. بالعربي المود هو المزاج. طيب إيش الأسباب اللي تخلي الشخص معرض أنه يمر بمرحلة depression or mania? There is the neurotransmitters theory, which is serotonin and norepinephrine are low in depression and dopamine is low in depression but high in mania. Also, there is psychosocial factor that can contribute to mood disorder, such as stressful life events, losing a loved one, losing a job, and lack of social support. طيب، ليش لازم نتدخل كأطباء؟ Because depression is considered the second leading cause of worldwide disability after cardiovascular disease, and shouldn't be taken very lightly, because major depression could be life-threatening. Okay, I want you to think of mood disorders in general as a continuum and a spectrum. From depression to mania. Depression is noted by low mood, while mania is noted by number of symptoms but mainly irritable or elevated mood. على السبكترم هذا راح نحصل اضطرابات عديدة. من جهة الاكتئاب راح نحصل major depressive disorders and dysthymia، ومن جهة المانيا راح نحصل bipolar 1, bipolar 2 and cyclothermia، وهذه الاضطرابات اللي راح أشرحها اليوم. بدي أبدأ اليوم في major depressive disorders. Major depressive disorders في DSM-5 الdiagnosis لازم يكون 5 symptoms من أصل 9 for 2 weeks at least. الsymptoms حطيتها في النيمونيك سيجي كابس، اللي هي لازم يكون في أول شيء depressed mood و no evidence of mania. We have to rule out mania ويكون عندي low mood. النيمونيك سيجي كابس أول شيء sleep disturbances, which I'm going to explain further. Then lack of interest, which is anhedonia, guilty feeling, energy loss and fatigue, concentration problems, appetite, weight changes, whether it's high appetite or low appetite, weight gain or weight loss, psychomotor symptoms, either agitation or retardation. I'm going to explain it further, but just keep in mind that psychomotor retardation usually come with depressive disorders. And lastly, suicidal ideation. Okay, so everyone has sleep disturbances. لكن وش اللي يفرق sleep disturbances that indicate a mood disorder than usual sleep disturbances? We have types of sleep disturbances: difficulty getting to sleep, it's initial insomnia, then waking up in the night, middle insomnia, then waking up earlier than usual or earlier than expected, which is terminal insomnia. We have hypersomnia, which is excessive sleeping, and usually in depressive patient, the sleep rhythms are altered. But with the prescription of antidepressant drugs, usually the sleep rhythms normalize after that. Okay, I mentioned psychomotor symptoms, either retardation or agitation. إيش الفرق بينهم؟ Psychomotor retardation غالبا تجي مع depression، و psychomotor agitation غالبا تجي مع المانيا. Psychomotor retardation فكروا فيها retardation ف everything is slowing down, slow movement, slow thinking, slow speech, slow to answer question as well. And the patient, when they're talking, they're using a low voice and fewer words than usual. In psychomotor agitation, it usually comes with mania. Everything is excessive, everything is fast. Their movement is fast and repetitive. The patient would feel inner tension. The patient would be fidgeting and pacing. They're using excessive words, and they would jump from topic to topic very quickly with no correlation. For the treatment of major depressive disorders, usually we use psychotherapy with the combination of antidepressant. The most common psychotherapies used are cognitive behavioral therapy and interpersonal therapy. For the antidepressant في محاضرة كاملة عن antidepressant، لكن غالبا نستخدم SSRI and SNRI. ولازم نبلغ المريض إنه antidepressant could take 4 to 6 weeks to assess efficacy. يعني إذا patient جاني بعد 6 weeks و still symptomatics, usually the psychiatrist would increase the dosage or add another drug or either switch drugs. For refractory cases of depression, major depressive disorders, or even psychosis, we could use electroconvulsive therapy. and if I suspect the patient has high suicide risk, the patient would be usually hospitalized. طيب على أي أساس أقرر إنه هذا patient has a high suicide risk وهذا patient has low suicide risk? We usually use sad person scales. أعطي point لكل واحدة من النقاط هذه. If the patient عنده 0 to 4, it's considered low risk. If the patient has 5 to 6, it's considered medium risk. If the patient has 7 to 10, it's considered high risk. So the sex, if it's a male, I'll give 1 point. The age, I'll give 1 if it's young adult or elderly. If the patient is already diagnosed with depression. If the patient has already a prior attempt of suicide. If the patient is using ethanol or drugs or has any substance abuse issue. If there is rational thinking loss, يعني patient ما عنده rational thinking مثل الحالات السايكوسيس فأعطيه point. If the patient عنده another sickness or illness or comorbidities, I'll give another point. If the patient has organized plan. If the patient has no spouse or social support. If the patient has stated their intent of suicide, يعني patient قال إن أنا عندي intention of suicide, I'll give another point. Other way to assess risk, but it's not used as common, it's ideation, plan, intent. Higher risk if all 3 are present. Ideation, the patient may say, I think about killing myself. Plan, the patient would prescribe a specific way of killing themselves. And intent, they have a plan and intent already. They would classify the date and the method they would kill themselves. طيب راح أتكلم عن other types of major depressive disorders زي depression with psychotic features like schizoaffective disorders, depression with anxious stress. The association between anxiety and depression is proved highly by research. And depression with mixed features, the patient may experience symptoms of depression and mania at the same time. Also, there is postpartum depression. It happens to mothers after delivering their baby, and for the diagnosis, the patient must have clear functional impairment. Lastly, seasonal depression. It usually comes at winter and fall times. The treatment depends on the severity, and some addition of phototherapy is used. Now I'm going to talk about dysthymia. Think of dysthymia as the chronic mild depression. يعني هو chronic لكن mild depression. في قاعدة عشان تذكرونها اللي هي the rule of 2. dysthymia لازم يكون more than 2 years ولازم يكون عنده low mood plus 2 of the following symptoms. عكس major depressive disorder كان لازم 5 symptoms, هنا بس 2 plus low mood. في نقطة اللي هي not free from symptoms longer than 2 months. يعني البيشنت قد يكون عنده mild depression لكن يكون في فترة هو مزاجه طبيعي بعدين يرجع للدبريشن. الفترة هذه ما ينفع تكون أكثر من 2 months. يعني إذا جت فترة مزاجه كان طبيعي 3 months or 4 months, it's not considered dysthymia. الsymptoms بتكون نفس major depressive disorder لكن less severe. We only need 2 plus low mood to diagnose. We usually treat with SSRI just like major depressive disorder. Okay, now I'm going to talk about the other hand of the spectrum, which is mania. What is mania? It's a distinct period of abnormally and persistently elevated, expansive or irritable mood and abnormally and persistently increased goal-directed activity or energy. It lasts for at least 1 week, present most of the day and nearly every day. Unlike depression, which has to be 2 weeks, mania is 1 week. Okay, the diagnosis of manic episodes احفظوها بدق faster. لازم يكون فيه irritable mood plus 3 symptoms at least for 1 week most of the day. Which is symptoms? Distractibility, insomnia, grandiosity, flight of idea, agitation, increased activity, sexual exploits, talking too much, elevated mood and racing thoughts. Basically the opposite of depression. Just memorize it by dig faster. طيب لازم تفرقون بين المانيك episodes والhypomanic episodes. هذا definition من DSM-5. المانيك episodes لازم تكون at least 1 week ويكون فيها functional impairment زي point 8 severe impairment in occupational and social functioning. This is the cornerstone of manic episodes. لازم يكون فيها severe impairment. بينما الhypomanic تكون 4 days at least no impairment. Point 8 as again less severe than manic and no significant changes in daily functioning unlike manic episodes. ليش لازم نفرق بين المانيك episodes والهايبومانيك episodes؟ لأنه المانيك episodes تجي مع bipolar 1 والهايبومانيك episodes تجي مع bipolar 2، فكذا تحفظونها. So definition of bipolar 1 on DSM-5 is 1 or more manic episodes plus 1 or more depressive episodes. في شرط إنه تكون not better explained by psychotic disorders، هذا شرط عشان نشخص bipolar 1. بينما bipolar 2 at least 1 hypomanic episodes plus 1 or more major depression episodes. في شرطين للهايبومانيك للbipolar 2 أقصد، اللي هي criteria never met for manic episodes plus not better explained by psychotic disorders. طيب عندي شيء اسمه rapid cycling depression or rapid cycling mania. إيش هي؟ اللي هي لا يكون في 1 year 4 or more episodes of mania or 4 more episodes of depression. فإذا كان 4 more episodes I call it rapid cycling depression or mania. Okay, treatment of mania. We usually use mood stabilizers such as lithium, carbamazine, valproate. I could use anticonvulsant as well. Usually we use lamotrigine. If the patient came with agitation, I use antipsychotic, usually second generation, olanzapine or risperidone. I could use also benzodiazepine, and in refractory mania, we could use electroconvulsive therapy. Okay, just like I mentioned, dysthymia is the chronic milder version of major depressive disorders. Cyclothermia is the chronic milder version of bipolar 2. وراح أذكر ليش قلت bipolar 2 not bipolar 1. لكن إذا تذكرون the rule of 2 هنا تغيرت شوي. It has to be for at least 2 years and not symptoms free longer than 2 months, just like dysthymia. لكن يوم قلنا إنه bipolar 2 لأنه it has to have numerous periods with hypomanic symptoms that do not meet the criteria for hypomanic episodes, and numerous periods with depressive symptoms that do not meet the criteria for a major depressive episodes. يعني عندي hypomanic symptoms لكنها it's not severe enough بحيث إني أقول إنها hypomanic episodes، وعندي depressive symptoms لكن it's not severe enough بحيث إني أقول إنها major depressive episodes. عشان كذا ما أقدر أشخص البيشنت هذا bipolar 2 فأشخصه في cyclothymia. Cyclothermia is related to psychosocial stress, obviously, and it has a strong correlation with substance abuse. That's it for mood disorders. This was my references, Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, and Kaplan and Soda's Comprehensive Textbook of Psychiatry, the 10th edition. This is my email if there's anyone interested in psychiatry or has any further questions, and thank you very much.